Welcome viewers to an exploration of relapsing polychondritis, a rare and often debilitating autoimmune disorder. In this video, we'll delve into the causes, symptoms, diagnosis, and management of this complex condition, shedding light on its impact on the nervous system and the body as a whole. The exact cause of relapsing polychondritis remains unknown, classifying it as an idiopathic disease. However, it's believed to be an autoimmune disorder, meaning the body's immune system mistakenly attacks its own cartilage. Genetic predisposition, environmental factors, and prior infections have all been suggested as potential triggers, but concrete evidence remains elusive. Research continues to explore the complex interplay of factors that may lead to the development of this disease. In relapsing polychondritis, the immune system targets cartilage throughout the body, initiating an inflammatory response. This inflammation leads to the destruction of cartilage, particularly in the ears, nose, trachea, and joints. The destruction of cartilage in these locations leads to the wide range of signs and symptoms. Specifically, the neurological impact can occur through several mechanisms: inflammation affecting blood vessels that supply the brain and nervous system, vasculitis; cartilage damage in the inner ear leading to auditory and balance problems, or in rare cases, direct inflammation of the brain or spinal cord membranes. Relapsing polychondritis is a rare disorder, with an estimated prevalence of around 3.5 cases per million people. It affects men and women equally, and can occur at any age, though it most commonly presents between the ages of 40 and 50. Due to its rarity and the variability of its symptoms, diagnosis can often be delayed. Data on specific ethnic or geographical distributions remains limited, highlighting the need for continued research and improved awareness. The signs and symptoms of relapsing polychondritis are diverse and can vary greatly from person to person. The most common symptoms include inflammation and pain in the cartilage of the ears and nose, causing redness, swelling, and tenderness. This can lead to a characteristic saddle nose deformity if the nasal cartilage collapses. Inflammation of the trachea can cause cough, hoarseness, and difficulty breathing. Joint pain and swelling are also frequent, mimicking other forms of arthritis. Neurological symptoms can include hearing loss, vertigo, and in severe cases, seizures or cognitive dysfunction resulting from vasculitis or other inflammatory processes affecting the nervous system. Eye inflammation, scleritis, episcleritis, and cardiovascular complications are also possible. Diagnosing relapsing polychondritis can be challenging due to its rarity and the nonspecific nature of its symptoms. There is no single definitive test. Diagnosis typically involves a combination of clinical evaluation, physical examination, and laboratory findings. Blood tests may reveal elevated inflammatory markers such as erythrocyte sedimentation rate at ES and C-reactive protein CRP. Imaging studies, such as CT scans or MRIs, can help assess cartilage damage and inflammation in the airways and other affected areas. A biopsy of affected cartilage can also be performed to confirm the diagnosis, but it is not always necessary or feasible. The diagnostic criteria, as established by Mischet in 1986, are often used to aid in diagnosis, and these criteria include things such as chondritis of both auricles, non-erosive inflammatory polyarthritis, chondritis of the nasal cartilage, ocular inflammation, chondritis of the laryngotrachea, and audiovisubular damage. Careful consideration of the patient's history, physical findings, and laboratory results is crucial for accurate diagnosis. While relapsing polychondritis doesn't neatly fall into specific types, its presentation can vary significantly based on the organs affected and the severity of the inflammation. Some individuals may primarily experience auricular chondritis, while others may have more severe tracheal involvement or systemic vasculitis. Understanding the specific manifestations of the disease in each patient is essential for tailoring treatment and management strategies. There is no cure for relapsing polychondritis, and treatment focuses on managing symptoms, reducing inflammation, and preventing further cartilage damage. Mild cases may be managed with nonsteroidal anti-inflammatory drugs and NSAIDs. More severe cases often require corticosteroids, such as prednisone, to suppress the immune system and reduce inflammation. Immunosuppressant drugs, such as methotrexate, azathioprine, or cyclosporin, may be used to help control the disease and reduce the need for high doses of corticosteroids. Biologic therapies, such as TNF inhibitors or other targeted immunomodulators, may be considered in patients who do not respond adequately to conventional treatments. Supportive care, such as physical therapy and respiratory support, is also important. Prompt treatment of infections and other complications is essential for improving outcomes. As the exact cause of relapsing polychondritis is unknown, there are currently no specific preventive measures. Early diagnosis and prompt treatment are crucial for minimizing cartilage damage and preventing serious complications. Individuals with a family history of autoimmune disorders may be at slightly increased risk, but the overall risk remains low. Maintaining a healthy lifestyle, avoiding smoking, and managing other risk factors for cardiovascular disease may help to reduce the risk of complications. The prognosis for relapsing polychondritis varies depending on the severity of the disease and the organs affected. Some individuals may experience mild, intermittent symptoms with minimal impact on their quality of life, while others may develop severe, life-threatening complications such as tracheal collapse or cardiovascular involvement. Early diagnosis and treatment can improve outcomes and reduce the risk of complications. Recent research has focused on identifying biomarkers that can help predict disease progression and response to treatment. Studies are also underway to evaluate the efficacy of new biologic therapies and targeted immunomodulators. Continued research is essential for improving our understanding of relapsing polychondritis and developing more effective treatments. The hope is that this research will help to improve the quality of life for those living with this challenging condition.